Dear colleagues, I would like to welcome you. My name is Nune Yazarian, the director of the Armenian Eye Care Project Charitable Foundation. I warmly welcome you to present the next meeting of the AECP Grand Rounds dedicated to corneal diseases. As always, this meeting was jointly organized by the Armenian Eye Care Project Charitable Foundation, Sergei Malayan Ophthalmological Center, and the Department of Ophthalmology of Yerevan State Medical University. Our meeting will be moderated by our Armenian and foreign partners. Anna Hovakimyan, Doctor of Medical Sciences, Professor for the Department of Eye Diseases, Yerevan State Medical University, named after Mkhitar Heratsi, ophthalmologist and surgeon of the Department of Inflammatory Diseases of the Eye, Malayan Ophthalmological Center, and a fellow of the Armenian Ophthalmology Project. Dr. Hill is with us as well. He's an ophthalmologist and he's the founder of Glacos company, and he's a founding member of the Armenian Eye Care Project and a board member. For the first time, we also have Dr. Francis Ma. It's a pleasure for us to engage new talented participants. I will present Mr. Ma. He's an ophthalmologist. He represents Scripps Clinic, director of the Cornea Service and co-director of Refractive Surgery Service. Later, Mr. John Hovhannisyan will join us. He's a doctor and the head of the Harvard Association of Ophthalmologists, Laguna Hills, California, clinical faculty at UCLA Jill Stein Eye Institute. And it is my pleasure to give the floor to Dr. Hovakimyan. Hello, dear colleagues. Allow me to express my gratitude to AECP on behalf of Ms. Ghazarian and her team. I would also like to thank Sergei Malayan Ophthalmological Center for their intellectual services and also their director, Mr. Miroyan. And I would also like to thank the staff of the Department of Ophthalmology of Yerevan State Medical University. I would also like to thank our colleagues who have joined us from the United States. Thank you for your time. Thank you for your participation and your contribution. Your contributions are always very valuable for us. And I would also like to thank all our colleagues who have joined us today. Today we are going to speak about clinical cases of patients. We have selected Pseudomonas aeruginosa associated keratitis cases. As you know, this pathogen is one of the most dangerous pathogens in the field of ophthalmology, which can lead to irreversible vision loss. So we will talk about the clinical cases, and we will also speak about immune keratitis. We can call it, we will discuss whether it's peripheral ulcerative keratitis, Mora's ulcer, or fluoroquinolone toxicity. So maybe our colleagues from the United States will help us to decide. And now I would like to give the floor to our clinical resident, Diana Lumanyan. She will read out the questions which our Armenian colleagues should answer for receiving the credits, after which she will come up with a report. Hello, everyone. Question number 1. Which surgical treatment method may be used to promote stronger epithelial adhesion in recurrent corneal erosion? A. Keratoplasty. B. Anterior stromal micropuncture. 3. Trabeculectomy. And D. Vitrectomy. Why are doxycycline and tetracyclines usually used in corneal ulcer treatment? They stimulate tear production, they inhibit matrix metalloproteinases and reduce stromal melting, they increase corneal thickness, and they directly destroy viral particles. Question number 3. Which is the primary purpose of corneal scraping in infectious keratitis? To remove necrotic corneal tissue, to reduce intraocular pressure, to identify the causative microorganism, and decide its antibiotic sensitivity to improve corneal transparency. How is peripheral ulcerative keratitis best described? Central corneal edema with endothelial damage, crescent-shaped destructive lesion of the peripheral corneal stroma, diffuse epithelial keratitis caused by viral infection, and corneal degeneration. Peripheral ulcerative keratitis is most commonly associated with which systemic disease? Diabetes mellitus, rheumatoid arthritis, hyperthyroidism, and systemic lupus erythematosus. Why are the peripheral cornea and limbal region particularly prone to immune-mediated damage? They contain more keratinocyte than the central cornea. They are closer to limbal vasculature and immune mediators. Peripheral cornea is thinner than the central cornea. They lack Bowman's layer. Which therapeutic mechanism explains the benefit of doxycycline in corneal melting disorders? Stimulation of epithelial stem cells, reduction of corneal hydration, inhibition of matrix metalloproteinases, enhancement of corneal endothelial function. Now, Diana Dumanyan will present a presentation dedicated to Pseudomonas aeruginosa associated keratitis. Hello, everyone. Today's presentation refers to our colleagues or dentists and the consequences of not wearing protective glasses and not following eye-related hygiene protocols. So these are rare cases, but they happen. So we have two clinical cases here, which are very different from each other in terms of course and pathogenesis, but they are common in that both patients are dentists, they didn't wear protective glasses, and in the cases of both, they had cornea epithelial damage. 35-year-old male complained of blurry vision, watery eyes, redness, pain in the eye. In the anamnesis, it is mentioned that a year ago he had this foreign body sensation, after which he used eye drops, and it seemed to him that the issue was resolved. But now he says that this is the fourth incidence. For the fourth time, it is repeated. Visual acuity OD 1.0, OS 0.7. Still lamp exam shows corneal loose epithelium and conjunctival injection. Taking into account the history and the examination data, the diagnosis is recurrent corneal erosion syndrome. And I also want to mention that it is important to do the diagnosis together with herpes-based keratitis, because very often patients with recurrent corneal erosion syndrome have been treated from herpes virus keratitis. So the diagnosis can be done based on the data that they have this sharp pain at night, which is very typical of recurrent corneal erosion syndrome, because at night when they are asleep, the cornea becomes drier, and after they open their eyes, epithelial removal takes place. Uh, Recurrent corneal erosion syndrome is a chronic condition which is the risk factors are previous corneal trauma. I mean, the surface trauma that can be done maybe by the paper or by nails, epithelial basement membrane disorders, which is common among diabetic patients, and also contact lens wearers. So, generally, the central or close to central areas are damaged. As for the pathogenesis, basal membrane insufficient formation and defect lead to disruption of stability of the epithelium. As for the management, we have use of topical mild steroids, FML drops, matrix metallothionein inhibitors, tetracycline, doxycycline, artificial eye drops, and as additional methods, serum tears and insulin drops are used. And if we still have incidents, then we do surgical micropuncture, which is basically an anterior stromal micropuncture with a needle, which leads to regeneration, improvement of regeneration, and stabilization of athesia. Here we can see the situation 1 month after the treatment. The second clinical case, which differs a lot in terms of complexity, 30-year-old male. He was complaining of pain in redness in his eye, and he mentioned that without protective glasses, he worked with patient's mouth, and part of the feeling went into his eye, and the patient also has has short vision. He didn't wash his contact lenses, and only after 7-8 hours later, he removed his contact lenses. In the next morning, he had severe pain, after which he was referred. He went to the polyclinic. He was referred to Dr. Hovakimian, and with still lamp, we can see the injection, this production from the eye, hypopyon, stromal and epithelial total edema. As by looking at the infiltrate and taking into account the fact that the patient wears contact lenses, we thought that maybe we are dealing with a Pseudomonas aeruginosa associated keratitis, and as initial management, we took a culture, and before we would receive the answer, we had proline solution. That's what we used. Betadine 1%, chlorhexidine 0.02% drops, and also oral doxycycline, tetracycline as inhibitors, cycloplegics, artificial tears. And on the next day, we called the laboratory to see whether we can get any preliminary information on what culture was developed on what type of glass. And they said that it's similar to Pseudomonas. And knowing that it's mostly tobramycin and ciprofloxacin sensitive, sorry, I didn't hear this part. And we were surprised that we got the answer. We got Pseudomonas, but the condition was stable. So Pseudomonas aeruginosa, sensitive to ceftriaxone, polymyxin, and meropenem. and only paralimexin could be administered in the form of eye drops. Unfortunately, we had this eye drop in our division, so we told him that he should administer it every 30 minutes, and we also um, administered, etc. And after 3 days, there was an impression there was a positive dynamic, but basically not as much. And we can see lysis, necrosis, and we can also have a perforation risk. We can see that the iris is penetrating, and around the infiltrate, we can also see expressed edema. And the patient is complaining of very sharp pain at nights. We made changes in the treatment. Ibuprofen was added, 400 milligrams twice a day. The patient's eye, 3 weeks later, we see some minor positive dynamic, but in the lower part, the edema around the infiltrate is approaching the limbus, and we were concerned that maybe the infection will penetrate into sclera. And so we decided that we will follow for 1 or 2 days, and then we will do penetrating keratoplasty. And because the patient had sharp pain, we decided to take the risk and also add prednisolone 50 mg, and we also added insulin drops and serum tears. The patient was supposed to approach us 2 days later. Then he called and said that he's observing certain positive dynamic and approached us 7 days later. Unfortunately, scleritis was milder. We can already see some vascularization, which shows some positive dynamic. And the edema is a bit slightly reduced compared to the previous visit. After 7 weeks, we can see that the eye is already succumbing to treatment. We know hypopyon, corneal vascular scar. We also added vitamin C per 500 mg twice a day. And now we can see the patient's eyes 6 to 8 months later. So we were administering steroids, and later we also have artificial tears, and now we can see that the scar is reducing, and after 1 year we will do after 1 year after the incident we will do keratoplasty, because Pseudomonas aeruginosa is considered one of the most awful infections, and we have had 2 more clinical cases in our division. I will briefly introduce them. In this case, a woman was doing some works in the field, and she noticed that the material she was using went into her eye, and on the first day she came with this situation. Antibiotics were prescribed, tetracycline inhibitors, and 2 days later the patient came with this situation: infiltrate, hypopyon, stromal edema. And so we took a culture. The answers showed that we again are dealing with Pseudomonas aeruginosa, which was not succumbing to treatment, and so we did penetrating keratoplasty, vision graft keratoplasty. This is the situation 3 weeks after the keratoplasty, and During the keratoplasty, it was coagulated, and we did the keratoplasty. We can see that currently the patient is under monitoring. The transplantant is uh, transparent. The shape is still not regular. Uh, and we also can observe minor cataracts. A few months later, we will also do the cataract surgery. The next case, the man applied to us and mentioning that he was treated with dendritic keratitis. This is the situation on the first day. We can see corneal irregularities. We thought that maybe we are dealing with herpes-based keratitis, and so we prescribed antiviral drugs. But 3 days later, he came with the following situation in his eye. So we realized that this is not succumbing to treatment. We took a culture, and again, we received an answer, Pseudomonas luteola, which is even worse than aeruginosa in terms of the course of the disease. And so we prescribed the drops, antibiotics, tetracycline, all inhibitors. However, 2 days later, the patient came with this situation: no anterior chamber, perforation, iris prolapse. And this surgery was done a few days ago. We did a conjunctival flap surgery. We don't have the next picture because the patient has not approached us for the next follow-up. We're following the course. This much. Thank you. Thank you for your attention. Thank you. I just wanted to make one correction. We did penetrating keratoplasty 1 year later, not 7 months later, because we always wait for 1 year. And now I would like to ask our colleagues from the United States whether they have any comments. Dr. Anthony,
Dr. Ma, welcome. Thank you for visiting us today, joining us today. And Dr. Hill and Dr. John, nice seeing you here. If you have comments.
I apologize for joining late. I was doing surgery. It's great to see all of you and my colleagues, both in Armenia and my colleagues from the US joining me. Hi, Francis. Hi, Rick. How are you guys?
Good.
For being here.
Yeah, maybe I'll start off at great cases, both of them. As far as the first case, pretty classic example of recurrent erosion syndrome. The other consideration might be some lag ophthalmos. I don't know about the history, but it's kind of in that exposed area. I noticed in the treatment, there was no mention, maybe there isn't availability in Armenia, but we use an osmotic agent, Muro, which is sodium chloride in white petrolatum. So it's beneficial because it helps to coat the surface of the eye, prevent dehydration, and then also it provides a little bit of salt, so it actually pulls some of the fluid out of the cornea. But either way, very well managed case of recurrent erosion. And then as far as the Pseudomonas, it's a huge problem. For us in the US, it's mainly contact lens use, which the first case, did show. And, correctly, you also worried about the scleritis, and it could be an infectious scleritis, which is why I think you use the ciprofloxacin. I was wondering, we don't really use Brolene or chlorhexidine for Pseudomonas, and I noticed that you continued the treatment even after you identified the Pseudomonas. I don't believe it's effective, and I think actually there's a lot of resistance.
Thank you very much for your comments. I have to tell you that when it comes to recurrent erosion, we do not have NILO, but we do have 5% natrium chloride. Just that sometimes patients complain that it stings a lot, and sometimes they refuse to take it. But we do provide sodium chloride, 5%, but we do not have the neuro, which is very good. As for Pseudomonas, on the first day, because the culture results were not ready yet, we had Brolin in our division because he was a contact lens wearer. We thought that maybe it's amobel, so we just gave it for 1 or 2 days. After we received the answer, and which showed that it's Pseudomonas, we stopped administering it because, yes, it doesn't help with Pseudomonas. It's strange that with Pseudomonas, ciprofloxacin, toprazamine, gentamicin, they have always been sensitive. But in this case, it was only polymyxin, and all accidentally, simply, we had polymyxin in our division because we don't have it in the pharmacies in Armenia. So we started to administer polymyxin every 30 minutes because only for that drug we had sensitivity, and the patient the patient also had a friend in United Kingdom. They sent the drug very quickly, and because it was very red, we didn't understand whether it was infectious or not. On sclera, there was no infiltrate, and so we took the risk of giving Premazalon 50 mg, and the patient said that this made his pain milder, but we gave it a few weeks after we administered antibiotics, because initially we didn't give it because we didn't want to suppress the immune system, and we didn't want to make the infection angry. And in his case, we were thinking of doing vision graft, keratoplasty, to save the eye, but he succumbed to the treatment, and now we're waiting for the 1 year to pass. And during our AECP conference, we will show the post-penetrating keratoplasty condition.
Yes. For me, that reminds me of the immensity of the clinical challenges that Armenia presents on a daily, if not hourly basis. In the United States, we deal with similar things, but at a much lower frequency. Keep up the good fight. Dentists in general, stomatologists, have a higher incidence of a lot of diseases. Actually, if you look at their incidence of hepatitis, it's double that of a cardiovascular surgeon. It's quite remarkable. The high-speed handpieces make an aerosol spray that is inhaled, and it's probably one of the main vectors. I also had a question about the chlorhexidine that caught me a little bit by surprise. What is your experience with the chlorhexidine? Of course, we use the topical betadine, and it's proven to be of great benefit, especially with the anti-VEGF injections that their retina colleagues give. But the chlorhexidine, I think we stopped using a while back because of corneal toxicity, and I was wondering what your thoughts were on that.
Well, we have keratoconjunctivitis cases recently. Initially, we administer betadine 4 times a day, 1%, which provides good benefits. Sometimes it's stingy, and that's why they refuse to use. With chlorhexidine, we now have demoptic relief. That's how the eye drop is called. It's 0.02% chlorhexidine. And as an antiseptic solution for conjunctivitis, particularly for adenovirus conjunctivitis, it's quite useful. And we do not have ganciclovir in Armenia currently. Before, we used to have it under the name Vergan. In the United States, it's called Zirgan. So it's 3% gel, which currently does not exist in Armenia. So mild steroids are quite good for conjunctivitis, and we do not have Brolin in Armenia.
What concentration of chlorhexidine are you using in this application?
Usually it's 0.02%, rarely 0.05%, and it's actually, I haven't noticed that much toxicity because we don't use
0.2 or 0.5%.
0.02 is available. Also, we have 0.05 0.05%.
Okay.
Both concentrations.
Yeah.
And if you use it for a couple of weeks, you usually don't see this much of toxicity.
Thanks.
Yeah, because we don't have PHMB, we don't have Brolin in the country, and if it's really true acanthamoeba, in some cases we just run into PK just to save the eye.
Speaking about toxic effects of chlorhexidine, yes, we do not use this eye drop a lot, but when it comes to adenovirus conjunctivitis, which is very common now, it is really helpful, both betadine 1% and chlorhexidine, on behalf of Benoptic eye drop. But it's because we do not have Prolin in Armenia, and we do not have PHMB, we do not have Curemycin. Very quickly, we have to do corneal transplant. There is keratoplasty to save the idea, to prevent it from entering the pathogen from entering the sclera. The second case will be presented by Datevik Alitsinyan, again a clinical resident. I would like to welcome everyone. First of all, I would like to express my gratitude to AECP and my clinical supervisor, Anna Viktorovna, for this opportunity to present. As you can see, today's topic is a very interesting case. From the title, you can already guess that we had doubts with regard to this final diagnosis, so we're going to speak about a clinical case which was similar to peripheral ulcerative keratitis or Murren's ulcer or maybe fluoroquinolone toxicity. Before speaking about the clinical case, I would like to speak a little bit about what peripheral ulcerative keratitis is, and then I will speak about Murren. PUK is a crescent-shaped destructive lesion localized in the peripheral corneal stroma of the cornea. Usually, it is with an overlying epithelial defect. PUK patients, one-third of them, also have scleritis, and PUK is also almost always also accompanied with autoimmune system diseases. The main complexity is the perforation of the cornea, the cause of which is the progressive thinning of the cornea. The PUK management is using immunosuppressants and also topical MP inhibitors, lubrication, and if needed, we can also do partial keratoplasty. Clinical case of a PUK patient, we can see the corneal defect 10:2. The patient had rheumatoid arthritis, which had already been diagnosed. Unfortunately, fluorescein picture is not here. I already mentioned what management we do in such cases. We can see the eye of the patient 3 months after the treatment and later 3 years after the treatment. We also did cataract emulsification. We also see the PUK part, and now we can also see the anterior stroma Murren's ulcer, which is clinically very similar to PUK, and is different only based on this unknown etiology. In this case, we do not have a systemic disease. Management is done in the same way. We can do amniotic membrane transplantation. Naturally, we also do lubrication, topical MMP inhibitor therapy, and also topical antibiotics treatment. Here we can see the eye of the patient with Murren's ulcer. Again, we can see corneal thinning, melt. And in the second picture, we can see the patient's eye after amniotic transplant, 2 months after it. So we can see the remaining result of the treatment, 3 months after the treatment initiation, 6 months after the treatment initiation. So we have stopped the thinning, stromal scar has been already formed, and this is the clinic. And now I want to speak about the clinical case. The pictures have been put with the informed consent of the patient, 65-year-old woman. She turned to us in September 2025. She was referred to us from a different hospital, saying that a year ago she was operated on. She had trichiasis, after which she had ocular surface inflammation, and she was prescribed levofloxacin. I'm speaking about her left eye. And we can see here that although the patient is 65 years old, she looks more older. She has a low mass body index. She is frail, and she has an expressed kyphosis. Slit lamp exam showed that we have folds in the cornea, which shows hypertony. We have hypopyon. The eye is not red, interestingly, and in case of infectious ulcers, the eye would be redder, and we would have also certain production, and we can see 95% thinning of the cornea here, and the fluorescent dye shows us that we have leakage of humor, which shows positive sidal test. In the left eye, vision acuity was hand motion. And when speaking about the right eye, I can say that we do not have any significant change here. Here we could only see 10% corneal thinning. As of the patient's history, medical history, I have to mention that according to the patient and according to her daughter, in 2022, the patient had acute sharp back pain. She went to did physiotherapy. She did stretching exercises, and besides that, the patient also had unexplained weight loss, gradual development of kyphotic posture. And back then, the patient was referred to an endocrinologist, and it was as a result. She had calcium deficiency. They did dosimetry minus 6.6, which means that the patient has expressed osteoporosis. Also, calcium determination was done, and the calcium levels were very low. In 2025, parathyroid tumor was removed in the patient. How the treatment was started? The preliminary diagnosis was peripheral ulcerative keratitis, because that was the clinical appearance at the beginning. We thought that the patient also has an accompanying systemic disease, so she was referred to a rheumatologist for consultation to detect the assumed disease. We did amniotic membrane transplantation, MMP inhibitor therapy was started, ferrotoxicillin, FML eye drops, tetracycline eye ointment, serum, and lubricating eye drops were prescribed. So we can see the situation 6 days after the AM transplant. To some extent, the folds have reduced and the pressure is increasing little by little. This is the eye of the patient 3 weeks after the surgery and treatment initiation. I have to mention here that the patient had already gone to the rheumatologist, and they had taken all the possible tests that they could take, rheumatological tests, and all were negative, as you can see. Here I want to mention that before AM transplant, in the surgical room, we did PCR test, culture was taken, and again, all the results were negative. So this shows that immune keratitis diagnosis was confirmed. And here we can see that the condition of the eye is better. We have installed a contact lens, and we also have a serum and insulin drops were prescribed. And this is the eye of the patient 9 weeks after initiation of treatment. Vision acuity is has increased to 0.1, and we can see the scar. And with the dye, we do not see any more leakage from anterior chamber. The situation is stable in the patient. Taking into account the overall appearance of the patient, we still could not decide, and one of the clinical residents proposed the hypothesis whether we can consider that a person maybe has a metabolic issue, which led to the peripheral ulcerative keratitis. And we asked our question to Keranet International Forum. And thanks to John Hovanesyan, we have their contact. Thank you very much for that. And so we tried to find our answers with them. Maybe some ophthalmologists in the world had already encountered such a pathology that maybe it has an accompanying metabolic disease. And Dr. Hümeyn Khan and Minas Coroneo. So levofloxacin was prescribed and the patient used it for 1 year. They mentioned that maybe it's due to prolonged use of topical levofloxacin because it is considered a MMP activator, and particularly in a patient like this who has an accompanying disease at such an age. And here we can see Minas Coroneo's answer and comment and interpretation. Minas later said that fluoroquinolones basically also damage stem cells, and they may lead to fluoroquinolone-related disability syndrome, which is quite a new entity, we can say, a new thing in the medicine. And the final diagnosis, we are still thinking, basically, we are thinking whether it's peripheral corneal melt, driven primarily by chronic topical levofloxacin toxicity, which occurred in the setting of a systemically fragile patient, or it's a Moran's ulcer because the rheumatologist does not denied any systemic disease. And maybe it's again due to the long-term use of levofloxacin. We should remember that it's very important to collect and properly and comprehensively collect a medical history of the patient. We should be careful with fluoroquinolone-based antibiotics use, long-term use, particularly in patients whose cornea is not in a very good condition. Thank you very much. Thank you, Datevik. And now I would like to ask our US colleagues to come up with comments, if any. Dr. Mann, Dr. Hill, Dr. Hovanesyan.
Any comments?
Yeah, this is a very interesting case. I was wondering, did you discontinue the levofloxacin? That's
immediately.
And did the
just the first day.
Yeah. So did the patient improve? Usually, if it's fluoroquinolone toxicity, as you probably researched or know, then immediately once you stop the fluoroquinolones, the patient's progression changes. But this is a very difficult case because it could be a secondary reason for obviously all the patient's issues, not the primary
Yeah,
for all
she
the.
had 360 degrees of leakage. So we immediately went into amniotic membrane transplantation to kind of cover the area. We stopped the levofloxacin immediately and started with MMP inhibitors and serum tears, insulin drops, lubrication, and
Yeah.
she improved in a
I-
week.
yeah. Oh, good. She did improve within a week. Yeah, that's great.
Was one of the blood tests. I couldn't read the form. By the way, very nice presentation, Datev. Also, Diana previously, very nice work here. Nice to see you guys. Was one of the blood tests an ANCA test, anti-neutrophil cytoplasmic antibody? Okay, so you
Right.
tested for Wegener granulomatosis, which would obviously be high on the list of
Right.
known causes, rheumatologic associated. So, yeah,
The
I mean, it's
rheumatologist ruled out all possible causes in rheumatic diseases. So we
yeah,
expected that they would say there is something, but there was nothing.
yeah.
So,
So. Yeah, I mean, it sounds like it's in the category of probably fluoroquinolone toxicity, possibly more. And there's no way to know for sure, huh?
right. We're happy it responded to the conventional
That's what
treatment with
matters in both
amniotic
cases. Yeah,
membrane, MMP inhibitors,
yeah,
lubrication.
yeah. Have you had much success? One of the previous treatments before we commonly used amniotic membrane for these melting cases was to do a recession of the conjunctiva just to move the vessels away. Have you done that in many of these cases, Anna?
We did the recession in case of immune ulcers, driven ulcers. If we are dealing with infection ulcers, uh, immune driven, in case of immune driven ulcers, we have to do recession rather than approaching. And so in this case, we have to recede the conjunctiva from the limbus to prevent immune complexes from approaching. But
Yeah, but it's very rare. It's not this common, this PUK or Moran ulcer. And
Yeah,
if it responds to, systemic immunosuppression, you just go with lubrication and that's it. But in severe cases, yes.
yeah. Okay. And then what's your next step with this patient? Are you confident enough? What's the vision like now, and what do you think?
Well, it moved from hand motion to 2200 because of the irregularity. She doesn't want to try any scleral lens, and besides, the patient is very poor, and she's happy with 2200. We just continue on lubrication, that's all. And she visits us once in a month. She's stable.
Yeah,
That
there
she
you go.
did get better with withdrawing the fluoroquinolines. I would vote for the fluoroquinolines.
Yeah,
Yeah.
yeah.
And obviously, nutrition is a problem in her looking at the bone densities. Wow.
Yeah, it was minus 6.6, and it was just amazing she was alive with these
Yeah.
numbers.
Oh, yeah. And she only had 360 degrees of leakage.
Yes, and hypopion and the melt of kind of folds of cornea.
Yeah.
Very severe
So
hypotonia, I would say.
you sutured
Typically a
the
normal case.
yeah. So you sutured the amnion. It was a little hard to tell from the pictures how you secured the amnion.
We just did a continuous one suture of 4 layers of amniotic membrane, the one that Ani usually prepares for us, drying on silica gel. And also, I think oral doxycycline worked, probably fluoromethalone twice a day as MMP inhibitor, topical tetracycline, serum tears, insulin drops. All this probably all together did some good job.
Yeah. In Armenia, Francis, we create our own amniotic membrane because we have lots of amniotic membranes at the maternity hospital, and it's dehydrated, and the patients are tested, and it works. It works just the same as the stuff we pay thousands of dollars for here.
And
And
it's
they
only
have,
$10 here.
yeah, yeah.
Yeah.
So it's get the job done. It's a lot of
Fantastic.
great lessons in efficiency.
Yeah, that's
So,
great.
Well, this was a great conference, and we want to be respectful of everybody's time. And I apologize for missing the first. I had to do surgery, and so look forward to I'll review the recording and get to enjoy it that way. So thank you for your hard work.
Yeah, very nice. Thank you.
Thank you
Wonderful
so much
cases.
for joining us and for your comments.
Allow me to thank everyone. In the first place, I would like to thank our young clinical residents, Diana and Tatevik, for wonderful presentations. And I think that it's also very important to thank our American colleagues. And I would like to ask you to read out the questions once again so that our participants can get their continuing professional development credits. And thank you all. I also would like to thank everyone, all our colleagues who agreed to participate in this meeting. Thank you, dear US colleagues, for your time. And your comments are always very useful and efficient for us because you keep sharing your experience with us. I would also like to thank our clinical residents, Tatevik, Diana, for their good presentations. And once again, I would like to thank the Armenian Eye Care Project. I think that Dr. Ma will hopefully also participate in the future as well. And Dr. Hill, so, of course. And I would also like to invite Dr. Ma to the September conference on the medical mission in Armenia. Thank you. And again, I wish you a good day. Our colleagues will now fill in their tests. Thank you.
Thank you, everybody. Thanks.
Yep, thank you. Bye.
Which surgical treatment method may be used to promote stronger epithelial adhesion in recurrent corneal erosion? A. Keratoplasty. Anterior stromal micropuncture. C. Trabeculectomy. D. Vitrectomy. Why are doxycycline and tetracyclines usually used in corneal ulcer? They stimulate tear production, they inhibit matrix metalloproteinases and reduce stromal melting, they increase corneal thickness, they directly destroy viral particles. Question number 3. What is the primary purpose of corneal scraping in infectious keratitis? To remove necrotic corneal tissue, to reduce intraocular pressure, to identify the causative microorganism and decide its antibiotic sensitivity, to improve corneal transparency. How is peripheral ulcerative keratitis best described? Central corneal edema with endothelial damage, crescent-shaped destructive lesion of the peripheral corneal stroma, diffuse epithelial keratitis caused by viral infection, corneal degeneration. Peripheral ulcerative keratitis is most commonly associated with which systemic disease? Diabetes mellitus, rheumatoid arthritis, hyperthyroidism, and systemic lupus erythematosus. Why are the peripheral cornea and limbal region particularly prone to immune-mediated damage? A. They contain more keratinocytes than the central cornea. They are closer to limbal vasculature and immune mediators. The peripheral cornea is thinner than the central cornea. They lack Bowman's layer. Which therapeutic mechanisms explains the benefit of doxycycline in corneal melting disorders? Stimulation of epithelial stem cells, reduction of corneal hydration, inhibition of matrix metalloproteinases, and D, enhancement of corneal endothelial pump function.